put us to the introductions, please? Thank you. This is Mercedes Byrne. I'm with the School of Social Work at the University of Iowa. I'd like to welcome you to the Nursing Home Social Work Best Practice Series. We have a lot of different webinars that we're going to be offering for nursing home social service staff, but this particular series is the Best Practice Series, and we're going to be talking about 15 best practices for nursing home social services. Paige, would you advance that, please? The 15 best practices are explained and included in this article that's published through the Journal of the American Medical Directors Association. And so if people wanted to know what all the 15 were, that's where they're listed. Next, please. Their 15 practices are based on work done by the National Association of Social Workers in the standards for long-term care settings, and also based on work done by the Veterans Affairs Office of Social Work Services, where they list the social work functions in VA settings. Next. And also, I wanted to let people know that the best practices are influenced by the Advanced GERO Social Work Practice Guide, which is a product that benefited from the John A. Hartford Foundation support and is now being housed at the Council on Social Work Education. So if you would like additional information on any of that, those sources, I just wanted you to know where to do it. Today we're going to be talking about best practice number 1, and this is the psychosocial assessment of residents and family members as a basis for interdisciplinary care planning and interventions. Slide. We have 2 speakers who have donated their time to prepare the presentation for today, Paige Hector and Deb Lane, and now let's find out a little bit more about each one. Paige Hector is a clinical educator and a consultant with 20 years experience in long-term care. She heralds from the state of Arizona, although she does nursing home social work and long-term care social work consultancies all over the country. Our speaker is Debbie Lane, also a social worker. She is LMSW certified and also certified in dementia care, so she's got extra educational experience in preparation in end-of-life care and dementia care. And she's been a nursing home social worker for 17 years, and she also is a consultant in long-term care. Okay. Just to remind everybody that the recording of this session will be posted within a couple hours after the session on the Nursing Home Social Work resource page, which is part of the University of Iowa's website for the School of Social Work, and also on the WebEx page that people went to register for today's session. All right. If you have a message or a question, please use the chat box, and I will be moderating the chat box, and our 2 speakers will not be paying attention to the chat box while they talk. I should let you know that they're going to speak until about 45 minutes after the hour, and then we will open up for questions. So if you have a question and you phone in, you can raise your hand electronically, and I will activate your call. Or if you are listening to this through the computer, then just include your question in the chat box. Okay, let's see. Thank you so much, nursing home social service staff, for what you do for America's families and nursing home residents. We really appreciate that. I want to let you know that there are 175 attendees listening to this live. All right, take it away, Paige.
Oh, thanks, Marcia, very much here. We're going to get these. Here we go. First of all, I wanted to say I'm honored and delighted to be part of the first speakers that get to present what I think are just critical things for us to know as social workers in the long-term care setting. So we're talking about psychosocial assessment impacting care planning and intervention. I to also be presenting with one of my own colleagues and coworkers at Deb Lane, talking about the crucial components of psychosocial assessment and then demonstrating how to use those to impact the care plan process. I can imagine we've got 45 minutes to cover what could take, a whole course, a semester or 2. So we're going to hone in on a couple of key topics here. The psychosocial assessment would not be complete if we did not bring in the NASW standards for social work practice, specifically the Biopsychosocial-spiritual Perspective when it comes to assessment. When you break this big word down, the bio really focuses on the physical and medical aspects. So the medical conditions, the issues that bring sometimes our residents or patients into the nursing home setting could be a combination of any of these situations. The psychological aspects are the psychological part, the sociocultural, the political, the economic, all the stuff that happens in people's lives from their communities, where they live, what they do, where they work, and some of the stressors and all the stuff that goes on with that is the social part. And then how to find meaning is the spiritual part. So it's a very brief framework that this is going to be superimposed over this entire talk. So that's the Biopsychosocial-spiritual Perspective. Obviously, for short, we tend to just say a psychosocial. One of the important point here that psychosocial assessment, I think we get into a rut thinking it's the initial psychosocial assessment upon admission. And I want to clarify that any time we go in to meet with a resident, patient, family, caregiver, involved party, we, in a sense, doing a psychosocial assessment. So whether we have formal tools or the questions that's in our minds, it doesn't just refer to initial assessment upon admission. They happen all throughout residents and patient stay. Go through this. I'm going to ask that each of you think about your own assessment tools. What do they look like? Are they useful to you? Have been using them for a while because that's what the social worker before you used, and it's just kind of the way it's been done? Or when you use them, do you sense a frustration or like I've got to use this form again? Maybe it's a quarterly assessment form or your initial or another tool. So this is a time to really think about and evaluate what do your tools look like, are they working, and are they useful? Capture information to paint a comprehensive picture. Recently, in fact, last week, I was asked to look at a quarterly assessment tool. And all the categories, that's where this word regurgitation in bullet number 2, basically what it was just a bunch of facts that were extrapolated, taken from the medical record, and put in one form. Now, in itself, that might provide some useful information, but the crucial components that were missing were the assessment parts. What was it that social worker was thinking based on all of the change that had happened over the last quarter for this particular resident? So think about your forms and lend themselves to really getting into the nitty-gritty of why people do the things they do, why they're having the issues or concerns that they have, and are they leading us toward ultimately the care plan, which this webinar is really making the link between the assessment and the care plan. The critical elements of care. Now, some of you may recognize this, but for those of you who are actually in a QIS state, the Quality Indicator Survey state, what I want to impart here is whether your state is QIS or not. So you might have a QIS survey, you might have a traditional survey process. The critical elements of care are read no matter what. There's some wonderful tools that are available in the QIS survey process. And this slide right here is very, very important because, again, it talks about there's 5 critical elements starting off with comprehensive assessment. We do nothing, whether it's nursing, dietary, activity, social work, no discipline in the facility can have any meaningful work done via the care plan unless there is a comprehensive assessment that's being done. You know, in this webinar, we don't have time to go through every element of what that would look like for a social worker, but I'm laying a foundation here, thinking about your tools. If you feel like those are just tools that you're having to do because you have to do them and not useful to you, that's your first hint. They may not be yielding information that would be defined as comprehensive and then useful. So comprehensive assessment is the very first, most important step before we can move to a comprehensive care plan. The plan cannot follow thorough and comprehensive assessments been done and down the line to implementing. So once you have an assessment, you go into a care plan, you implement the care plan by people who are qualified, you read the care plan as needed, and provide the provision of care and services. So that just means that we're doing what we say we're going to be doing. So I put it in there with the corresponding tags, so the Code of Federal Regulations, the citations, a picture of those. This title of this slide, Life History Provides Major Clues. I just love that. That is from Caring for the Ages. It's a provider magazine, American Medical Directors Association from AMDA. And what this really spoke to me about, and it wasn't geared toward any one discipline, it was in general life history, and I thought, oh, that's such a great idea. And that's what social workers really do bring to the table, that we look at the picture, the bigger picture from before this person, before they became incapacitated or disabled, or before they wound up in the hospital. All those clues from life history that provide us information that help guide us into a great care plan. So from a behavioral point of view, understanding why someone's behaving that what we deem unusual or disruptive makes staff easier to accept it if we can understand the whys. That's where social workers are so important, because we help get to the whys. This quotation here from Dr. Evans, who's one of the leaders within AMDA, I'm just going to read it quickly. He says this, meaning in general, this isn't premeditated, conscious mischief. This is someone responding to their environment in a way other people don't want. We need to substitute something meaningful for behavior that might be unbearable. So in other words, what's the history, what are the clues that we can garner that can help us substitute something that's more meaningful for residents? Our role, social workers. We determine the reason, the rationale. We're going to talk about need in a moment. But what is the reason and rationale? So we have to assess it. So got back to comprehensive assessment, use skills as social staff, this into a discussion perhaps directly with the resident, the patient, family and caregivers, other staff that are involved, to understand why this particular whatever it might be, behavior issue is happening. We assess it, we document it thoroughly, we then communicate with the team, so that communication takes place in your building. We do different structures, whether it's a daily stand-up, whether it's a shift-to-shift kind of thing, whatever the structure is, that the social worker's role is so to communication with all of the team members. And I want to make the point that team really include people that we may not think of from a clinical aspect. We remember folks like the dietary staff and housekeeping or laundry staff, sometimes maintenance staff. There are certainly instances when those important folks need to be brought into the picture to understand a specific component of a care plan that might in fact impact them. If they're in a resident's room and we're dealing with a very difficult behavior, they need to know, gosh, if Mrs. Jones does this, this is how I respond. Please think outside of what we might deem clinical. Of course, what we're talking about is the updating of the care plan. When we think about a need, I prefer, instead of saying problems, I tend to think of things as needs. If you get the definition, which I like to look at words up, a need is defined as a condition or situation in which something essential or desirable is required or wanted. Now, I think it's important to say that the essential or desirable might be, it's important to understand that's defined by an individual who's expressing the need. So it's not a resident in your facility that maybe is having a very challenging behavior. Maybe he or she is demanding to go outside and smoke cigarettes, maybe 15 times a day, because that's what they used to do in the past. But you have a smoking schedule, you have a supervision schedule, and it's, 5 times a day, so whatever it is in your building. So they might feel it's essential or desirable, but it's not going to work within the constraints of the facility. So it doesn't mean that it's wrong and incorrect, but we as social workers have to figure out a way to do something different to help that person be successful within the nursing facility. So we have to keep in mind that people's perceptions of a settled and desirable state or conditions are what we are often working with. Now, for those of you maybe haven't looked at Abraham Maslow's hierarchy of needs and maybe rolling your eyes thinking, oh my gosh, is she seriously bringing in into the webinar? But I got to thinking about needs and how important it is that we take a look at what these needs are and that they are met in order of the hierarchy, because if they're not met, that's when we see problems. Problems in our facilities typically manifest as what we might lump together as behavioral or emotional problems. So taking a look quickly at the hierarchy for food, water, sex, sleep, homeostasis, and excretion, the bottom level, the rung of his hierarchy, if those things are not met, that according to the perception of the individual, of that resident, there's definitely no way we can navigate up this pyramid to a more perhaps well-adjusted, well-adapted, happier, more productive individual. So social workers, we have to start here. So again, think about your assessment forms, your tools, your own skills, the questions that you routinely ask residents. Are we really meeting the order of these needs to really get at what the issues might be that are facing our residents, maybe causing some challenges? Once we do that, once we look at the needs, once we really focus in and ask some great assessment questions, here's some wonderful things that I have seen that social workers can contribute. I'm not going to read all of these, but I want to take a couple and read them, because these things directly come from great assessments that social workers have done. For example, bullet 1, resident work nights, so that might be why he won't go to bed when everyone else does. Worked for 30 years as a nurse and especially enjoyed the pediatric unit. Her dementia is advanced, but she might enjoy caring for her patient. These are what I call gems. They are just unique, wonderful things that we learn about people that can help us help them be successful in nursing home placement situations. Just one more. Resident's middle daughter overdosed on prescription medication 10 years ago and died. Resident is afraid to take her morphine routinely, even though her pain negatively impacts her quality of life. I'm constantly hearing social workers. We have got to be part of pain management, assessment, and implementation of interventions. This is a good example that, to me, this is the essence of social work, to get into a comfort zone and a trusting relationship with another person to something as important as that, which clearly impacts your residents' quality of life today. All the wonderful social work intervention that you would be able to do, just knowing that the reason she's afraid is because of the death of her daughter. Very real, very frightening, but gosh, there's so much we could do around that. So these social worker contributions based on comprehensive assessments. Okay, we're going to go into, I've got about 10 minutes left. I'm going to talk briefly about goals and how they relate to assessment, and I'll turn it over to Deb. One of my favorites, and I really have no links to these folks except I love their work and they know it. There's a great book out there, the New Care Plan Answer Book for Activities, Psychosocial, and Social Work Programs, MDS 3.0 edition. It's available online, but some of the stuff comes directly from that. I talk briefly about goaling food and behavior problems. So oftentimes, now think honestly about the care plans you have right now in your facility. I would be willing to bet that if we looked at charts from every one of your buildings, we find examples of care plan goals exactly as they are written here on the slide. They are addressed by reducing the frequency, the number, because it's theoretically measurable. Typically, we can measure something when it's reduced to this number or increased to another number. So we tend to focus on what it is that's maladaptive, disruptive, harmful, intrusive, whatever word you want to put in there, we tend to focus on that particular adjective, and then we say, let's just reduce it. Liz, we're going to reduce this feeling, whatever it is. And by the way, we're going to reduce it to this number. When I do this, I just clench up inside because I think, this just feels so negative to me. So I like to propose another way, utilizing psychosocial assessments to directly impact the care plan and the goals. Before we get to that pivot, think of this, that if you say, let's say, for example, racial slurs, we are going to reduce those 3 times a week, or maybe once a day. Sounds kind of good. Yeah, it would be nice if Mrs. Jones didn't, call her roommate or other residents by inappropriate and hurtful terms. The fact that we say reduce it to 3 times a week, 1 time a day, whatever the number is, fill in the blank, it's the message that behavior is still permissible, but just not as much. So I'm going to advocate that we do something different. The challenge we have with the current way a lot of us do care planning is really how accurate can we record something. If you say we're going to reduce something to 1 day, 3 times a week, whatever it is, what actual day? Is it the 24-hour, 8A to 8A the next day? Is it the shift? So what specifically do we define as day, and how to really capture that? Do we have somebody that literally follows the resident around and counts the data, the number of times or whatever that this does or doesn't happen? And then put all this. I would bet that very few of you could honestly say, wow, we have a great our behavioral management documentation program. Everybody is on board. We captured every shift. We're all in agreement. So there's a lot of challenges when it comes to capturing and recording data. Think about some of the maladaptive and harmful and challenging behaviors we have. Let me frame this in a different way for you. If you think about those behaviors, so take a second, think about a resident in your facility. They have distress, whether yelling out, they're crying, they're racial slurs, they are disruptive in some way, shape, or form. If you can frame it in a way of thinking about it as a mode or a means of communication, instead of restricting or inhibiting it, focus our efforts, at least initially, on determining the underlying cause. So we're tying this into assessment, needs. What is the need? What is the unmet need not for this particular person at this time? Why are they having the behavior? What I like to ask staff a lot, what's your assessment of that? What's your assessment of that? Pain and loneliness, fear, confusion, delirium, substance abuse. There are so many things that can contribute to why people behave the way that they do. Once we figure out that information, those gems, those yummy things that give us hints and clues about why people do what they do, that is what we base the goal on. The goal on the causal factors, that things causing the behavior, not the symptoms. The symptoms being the crying, the tearfulness, the yelling out, the racial slurs. Those are simply symptoms. That's productive to base anything on that to just reduce those. Here's some examples. So they're what I would call useful goals for depression. Residents will respond positively to counseling sessions twice a week with social worker to identify strategies to adjust to long-term care placement. So tell with that example, it is measurable twice a week. We think this individual something positive, something that we want to have happen. So instead of saying reduce, minimize, get rid of, kind of negative, what are expecting people to do instead? When you're talking about behavior that if a person's had all of their lives, they come into your facility, now we just want them to reduce or minimize or get rid of it altogether. How realistic is that? And quite frankly, what are they supposed to replace it with? So this is a really neat example of responding positively to counseling, so it's very clear in what the goal is and how it's going to benefit the resident. Now, the resident will verbalize 2 strengths during visits with the social worker that will help her adjust to placement. The interact in any demonstrable way with staff who visit to provide support 3 times a week. You guys, those are measurable, they're positive, they're trying to achieve a quality of life for the individual and not just saying, oh, you can only 3 times this week, Mrs. Jones. Different framework for thinking about goals. Strengths perspective for just a couple of minutes. This perspective on social workers, this is one of the most cardinal values that we hold dear, focusing on people's strengths and bringing those to light in our facilities. All of us, no matter who we are, what our backgrounds are, what our challenges in life, no matter what, we all have strengths, and so do our residents and patients. So social workers, think about now, let's tie this with assessments. Your assessments, do they ask appropriate questions that allow you as a social worker, as the assessor, to bring light, to find out and discover what people's strengths are? Her strengths, their resources, what do they have that we can help resolve or minimize or help make something better today? Can we help them based on their past successes and strengths to solve personal and environmental problems? How maybe you can identify when in the past they've been successful with a similar problem. To solve that, how did it go? What worked? What didn't? And get factors that contribute to growth and well-being in general. Here are some strengths. Now, this comes from Kelsey Simons, who's one of the participants and planners for this Best Practice series. She's one of the premier leaders of research in the country for social workers. This comes right from her work and some other folks in 2005. Very simple, very direct questions that if are not part of your assessment tools, you need to get them in there today. So what consider your strengths? What makes a good day? The things you do each day or each week because you really prefer to choose, but not because you must. So I read all of these, but this gives you the gist of some wonderful questions to help you find out some great information to use in the care plan. Then what do you do with that information? We use strengths in care plan. I've reviewed hundreds and hundreds of care plans, and one of the things I've seen that you do all the needs or problems, however your system defines them, and then I've seen so many facilities have a care plan that actually says strengths. And one care plan, a single page, they list a bunch of strengths. What good is that when they're extrapolated and separate from other care plan, the problems and goals and approaches? The strengths need to be utilized within the care plan, throughout the care plan. So whether it's diabetic management, how a resident finds success into not wanting to use her spare change in the candy machine, those are things that social workers can do. So with strengths, we chat about the strengths. Hey, Mrs. Jones really does this great. So when she begins to do the behavior, get engaged in doing this, and she'll stop doing that. Empowering people, getting them some control back, and empowering and encouraging them to remember, oh, you do have a strength. You know what? You can do this, and we're going to help. Here's a quick list, some examples of strengths. Goal setting, that they have the ability, they're positive, they can be redirected, they can feed themselves, smiling. The strength that a resident can engage with a smile. They vision, they can ambulate, they can verbalize, they can make our own decision. These are all great strengths that our residents have. So here's just a couple of examples. And again, this comes from another very good book called the Social Work Care Plan Training Manual 2. Providing residents with opportunities to make simple, no-lose decisions. The resident to try to calmly communicate what he wants to say. So perhaps this individual had a tendency to yell and scream or speak down or derogatorily choose members when he wanted something. But yet he'd been able to demonstrate that he can speak politely at a regular tone of voice. So right there, ask the resident to try to calmly communicate. That's a wonderful approach that you social workers would have learned from your assessment, then taught to your staff, implemented via the care plan. The resident in singing or humming. A neat example of a resident who we let her favorite song in the world was Take Me Out to the Ball Game. Yes, we told the staff to use when it came time for her to take a bath, and she tended to be resistant to the bath. Well, we heard the staff sing and Take Me Out to the Ball Game with her. It was wonderful. It worked. So we got her engaged in something else she was able to do. So again, this is just a list. There's so many examples of strengths and approaches. My slide before I turn it to Deb here in the next moment, I want to give you an example of an approach that might be a little bit different than what you might be used to seeing in your own care plans. I'm going to go ahead and read this to you because I think it's so, I'm the word yummy again. I just love that word, that it's so yummy, and thinking about how the social workers can really impact and make a difference with residents. Here it goes. When the resident expresses sad thoughts, listen attentively. Acknowledge that the admission process often evokes strong feelings. Give her a kind ear. Do not attempt to talk her out of her feelings. She has every right to feel whatever she feels. Later, ask her what she might do to start feeling better. Recognize that she is not alone in feeling upset or distraught. The long-term care facility evokes many emotions, and it often helps to talk about one's experience. And you notice in parentheses, we look at all these disciplines responsible for carrying out that approach. Work activities, nursing, and CNAs. Everybody. Everybody's responsible. It's very clear direction to staff. So instead of when they go in and she's crying or she's upset or she's angry, oh, Mrs. Smith, it's going to be fine. Don't worry about it. Oh, wouldn't that just crush you if that was you feeling upset? And it gives the staff very clear, this is what you can do instead. Okay. I turn this over to Dan. I'll still be advancing slides, but she's going to give you a wonderful example of a resident that she has in her facility, and an example of how she utilized the social assessment component, some of the questions she asked, and the wonderful implications that it had for her care plan. Oh, yeah, take it away.
Thanks, Paige. And this might also help answer one of the questions that came up on about a good assessment, because these questions are integrated into my assessments. So first we have the case scenario of Mrs. T. She's an 81-year-old married female. She was admitted to the nursing home due to multiple falls in her assisted living community. She has a daughter who lives locally who came with her to the facility to help her get adjusted. And her husband, she's well known to the community because her husband has lived in the nursing home 3 years previously. Questions that are asked when someone comes into the community are, we want to know what their daily routines are so that we're not disrupting some of their regular routines. You know, what time is she used to waking up and going to bed? What's interesting is breakfast hours here are about 7:30 in the morning. Well, she doesn't get up at 7:30 in the morning. She likes to sleep till about 9:30 or when she normally wakes up. She does not want someone waking her up. She wants to wake up naturally. And she goes to bed later. She doesn't go to bed right after dinner. She likes to sit up and watch the news. You know, does she normally like to eat? Interestingly, this is a woman that skips lunch. And in nursing home, it's very difficult, especially when you have your dietitian coming in and you have the state surveillance looking at you, of, you know, you have a resident that's not eating 3 meals a day. How are you making sure that their needs are being, how are you making sure they're getting the calorie intake and everything? So we're working with the dietary staff on, you know, if this is how her routine is, how are we making sure we get the calories in her? In her situation, she has a very unusual lunch, which specifically I will tell you is an English muffin sandwich, which includes grape jelly, fried eggs, onions, and tomatoes. If anybody out there thinks that sounds tasty, please let me know. But that's something that she likes, and we make sure that she has that every morning. When we looked at coming in, we were looking at whether or not, you know, she was going to room with her husband, and the answer to that was no. They always lived in separate rooms. This help us understand the prior level of functioning. Why does she need the nursing home level of care? She needs the level of care because she's had multiple falls. She's had a change in her ADL status. She could no longer function at the assisted living level of care. She needed a higher level of care. And how was she performing those ADLs and IDLs at home? She was really not allowing the assisted living staff to assist her with some of her care because she felt that that was not a nursing home level of care. So she was trying to do more things independently, and that was leading her into problems which presented her in the into the nursing home. So very few services were provided. She was just accepting assistance with showers and with medications. Slide. Who does she rely on? Needing to understand the family dynamics. Her husband's already in the nursing home. Is he somebody that she was relying on, or was she actually the primary caregiver? He is a support system to her, but he is not able to support her. So she very much relies on her daughter that lives locally, and daughter wants to be involved with her care and adjustment. Her husband actually has a private caregiver that is also involved with the care and adjustment. And, we're looking at the relationship between her and her daughter and her husband because it actually is a strained relationship. So although they are involved, there's some sense of strain in there where the daughter needs some time to break away from her mom. And the staff also understand that the daughter isn't around for certain reasons. One of my favorite sayings, and I shouldn't say favorite, but one of my sayings that I tell the staff here, because we only get to know the residents once they're impaired, is just because the resident grew old doesn't mean that they grew nice. We know how they raise their children and let the children tell us. And we can't expect that resident to change their personality just because they came into a nursing home, or all those family dynamics to change once they come into the nursing home. So that's something I remind my staff about on a pretty routine basis when they say, why isn't the family visiting, or why did they just get in an argument? The next slide is we want to look at all of the mental health, the coping skills, and the emotional well-being. Any history of any psychiatric care in the past. We may not be a behavioral nursing home, but we don't want to exclude mood and behaviors from our assessment because it is an integral part of the entire person when they come in. And if they do have psychiatric care, they do have an illness, whether it's depression, whether it's a different form of dementia, whether the person is schizophrenic, bipolar, are they on any medications? Have they had side effect medications in the past? What has worked? What hasn't worked? Cutting in history on that so that you have. And then what is her history of coping? What Mrs. T has told us regarding her coping skills and what the family has told us don't always line up. So you need to get that information from more than one source. What are the losses? Because when it comes into the nursing home, obviously moving to the nursing home, whether it's temporary or permanent, they had a loss, whether it's their home, whether it's their ADL function, whether it's their cognition. But you also need to look at the past 5 years. Have they moved from, in her case, from a home to a retirement community to an assisted living, all within the past 5 years? That's a lot of moving. That's a lot of losses. And is there anything that's unresolved in this situation? She has a son that died of cancer at the age of 19. So, and that is still very heavy on her heart. So that also affects any time an illness occurs, any time something changes with her or her husband, how she copes with things. Slide. And then getting on to, that's the initial assessment. We're moving on to 3 months from now, or any change of condition assessment that is occurring. What changes have happened with her in the past 3 months? Have there been any mood or behavior medications changes since her last review? What were they, and again, why? Were the side effects? Were they not effective? What was going on? Was physician changes? The interesting thing in this particular resident case, which is very unusual, is she actually had a physician that died. And so we had to work on getting a brand new primary care physician for her. That was something that we had to integrate and get that physician to understand all of her past history. Have there been physical changes that have contributed, to mood or behavior when you don't feel good? We've got the flu going around Arizona right now. that's something, when you don't feel good, your behavior sometimes, you get a little testy with people. So are those things that are affecting her mood and behavior? Has there been a death or a change, within her family? Her daughter initially lived out of state, moved back. She has more family support. And any other losses, that she is having to be coping with. The next slide. And we really need to include the staff. What are the staff saying? I mean, we can, as social workers, we can assume that, oh, gee, I haven't heard anything lately, so things must be going well. Assume. Talk with the staff. Ask them, because they don't necessarily, the staff don't know when there's been medication changes. The nurses know, but ask them. Sometimes they do get busy. Sometimes they don't, chart on those behavior records. How is, Mrs. T doing? How have things been the last couple of weeks? Have you noticed any changes? And you say, well, why are you asking? Well, I'm just kind of curious. I want to know, is she still yelling at the staff? Is she still accusing you of taking things out of the room and whatnot? And the staff start thinking, oh, you know what? Now you think of it, I haven't heard anything in the past couple of weeks. I'm like, okay, that's good. Because then when it comes up time for her next physician appointment, you can say, guess what? The medication changes or the environmental changes or whatever you have done for your approaches are starting to work. Or on the flip side of it, they're not working. So you need to assess and see what really can work. And what are the staff saying about the mood and behaviors? Is there a pattern? Are the staff saying, well, nothing ever happens on the day shift, it's always the night shift? Or it's only when the daughter visits or after the daughter leaves. So, what are we looking at those? Are there changes, as I mentioned, to the medication that affect it? And what are the environmental factors that might be contributing or changing her mood and behaviors? In some situations, in this particular case, she did not tolerate rooming with her husband. She did not tolerate rooming with the roommate. So the family was agreeable to a private room. And many of the behaviors subsided once she was able to go into a private room. So that was actually very beneficial and helpful. And then looking at, how quiet the situation is, how not she shuts her door at nighttime, things like that, very beneficial to her. And then lastly, I put on the last slide. Personalize the approaches. These are actually some of the approaches that we have on this residence care plan because your staff to really take credit for what they do. There's a lot of things that those CNAs and a lot of things those dietary staff and even the housekeepers do on a daily basis that you need to be aware of because they are little approaches and as I would say Paige calls them those little yummy gems that the staff are doing that they need to take credit for, they need to get credit for because when your state surveyors come in and they see that you're doing these and these are on the care plan, they go, wow, and watch you follow through with them, and they're really impressed. And, it's a nice pat on the back for the staff that don't get the pat on the backs. And you're kind of the liaison, the social worker being the liaison between the other staff of what they're doing. So a couple of examples that I did put is, Mrs. T is very private. She does not like to ask for help or have male caregivers. So we have female caregivers assigned to her when able, understanding that that's not always possible. And she doesn't like to be educated on proper techniques. She views that as lecturing and belittling of the staff. So we have an example here of when the staff catch Mrs. T in the bathroom and she didn't ask for assistance or transfer. She didn't put on a call light. Instead of telling her, how did you get here, or why didn't you put on that call light, say to her instead, I see that you need to use the restroom or you're done with it. Let me help you finish up. And instead of telling her, grab into the grab bar and do this, say, please hold on because it will help me. If she feels that she's helping you as a staff member, it makes her feel much better. Next one. Continue on. She misinterprets humor. You can't joke with her, so you have to remain professional. There are some residents that you have such a wonderful relationship with, and you can humor back and forth and you can banter with them. This is not a resident that you can do that, and so the staff needs to understand that. I mentioned about the private room. I mentioned about the lunch and her sleeping late. She has a psychologist that she follows up with weekly and a psychiatrist that follow up with her for her medication management. The next slide. To praise her when she's coming out of her room and exhibiting positive affect. She is somebody that cries frequently. She is somebody that accuses the staff of different things, and it will set the mood for her whole day. And it's also semantics of wording with her. So I observe that she's having a good day, that she's smiling, she's conversing with staff without accusations. State, I'd like to see you when you smile. You look happy. Because it urges her to tell the staff what is making her happy today. Whether it's she got the grape jelly right from the dietary department, and so she had the breakfast exactly how she wanted, so that made it a good day for her. But on the flip side, you must be careful with your words. If you state you look happy today, in her mind, she says, well, happy yesterday? Well, why do you think I wasn't happy yesterday? So that is something that you also need to look at and help the staff understand. Personalize her room. She likes to be in control of things. She has an appointment calendar in her room. Make sure that it's up to date and have her daughter actually participate in that so she knows when her doctor appointments are, when her hair appointment is, when specific activities are, because that is something that she refers to. And really maintain the contact with the daughter, because things that you might not be hearing or seeing from the staff, the daughter may be seeing or hearing. And you know that, hey, I think this is working, or guess what, my mom said that this staff member did such and such. And so you're able to figure out actually what is behind the statements and the reasonings and all of that. So that is it for the case scenario and the personalized care plan. I think Paige and I are open. I will say I do see a question from Elizabeth that says recommend a caseload per social worker. Elizabeth, I work in a nursing home of 60. So I actually oversee, and I am the only social worker. So I oversee all 60 residents, and within that there is a 16-bed dementia unit that I also oversee. So it's a lot, but it is manageable. Okay.
I know that you're there as well. I'll just say, Robin, you had a question about ACT, and that came from the slide where I had the interdisciplinary approach to care planning. ACT is just a brief abbreviation you see a lot on care plans for activity staff. So.
Also, there are some questions in the chat box if our speakers want to look at that. And in the question and answer, we also, while people are thinking of their questions, we have a poll that to be put up with just 2 short questions. We're wanting to know whether or not people's facilities are part of AYA or leading age. And so please fill out that poll. And let's go back to questions.
Okay, first I'm seeing one here. I think I'm following this okay. Yes, the handouts are available. We got that on there. Psychosocial assessment. So it looks like let's do this, Mercy. I carry literally, it's a 5-inch binder of tools and resources that I personally have collected over many years. Some are electronic, some of them are not. We do have some things that I think might be helpful if we could scan and put in. I'm not sure what to do with that to best help get assessment there to people, but I think the other thing that I have seen is on the University of Iowa, on the social work listserv, I know at some point in time this exact question did come up, and some of the participants were so generous to attach their own assessments. How best do you think we can handle that question?
This is first. We do have the website, the Nursing Home Social Work Resource page, and anything that people would like to share with other nursing home social service staff, just email it to me, and if you have permission to share it, that is, and then I'll just post it on the Nursing Home Social Work Resource page, and then it's available for other people. So I cannot put up copyrighted materials without permission, but like if you have certain questions that you've used and found helpful, or like the books that you talked about today, we can put that kind of information there. And so, Paige, anything that I know you said you have a lot, maybe just start by sending one or two things over that I can post, and then people on the listserv do add things, and people on this call could also add things. The other thing is we're always looking for what our nursing home social workers want more training on. So, yes, we do have the next 15 sessions planned, but we can be adding more sessions every month. So if there are specific things that Paige talked about or that we talked about today, and you would like more information on it, many times I know Paige said we don't have time to do it today, but those things, let us know, participants, and we will do what we can to plan a special session, a webinar session, around any topic that you would like.
Hamer, I just want to say, too, real quickly, and I'm looking frantically through my literally 5-inch binder here. There was a great article, and I'm embarrassed that I don't remember the authors on it, that talked about caseload. Was it where's MERS?
Yes, I did a national. I asked people how many nursing home residents psychosocial needs they can match, and you know what? I'll put that table up on the resource page. Ask the question based on long-term care, chronic care versus subacute, and the punchline is maybe half at least said they could take care of 60 long-term care residents' psychosocial needs. Would be the maximum per
20 subacute,
Right.
I personally, I carry that article with me when I'm in a new building. I think it's a gem, and I think it at least gives a framework for especially administrators to understand in order for social workers to adequately cover. And this is just in what Deb and I talked about today, is what truly a complete psychosocial assessment entail. The other resource that I would like, I'm going to click over here. I just put up on the screen recommended list of resources. It happens to be one that I've compiled, but there's so many more. This is one that I refer to a lot, some of these things. Oh, there's right there, Merce, the very first one. There's some really great things that are available, those training manuals, policies. There's a lot of things that these books can give you. And I have found that some of the very best forms that people use are ones that they come up with themselves. Look at some of the resources that are out there by the folks like Mercedes and other people that it gives us the components of a psychosocial assessment, the social work care plan training manual, the policy procedure book there in the middle. There are some great, great resources that if you were to look at the psychosocial assessments within those books, and quite frankly, anytime a social worker is able to financially afford some of these books, it's great because you can mark in them and mark them up and scratch all over them. But if not, that's okay too. Hit your administrator up. Go in and say, I can do a job as a social worker, but I need some resources. This is exactly what I need, and this is what it costs. Wink at it. So it's the component of advocating for ourselves as well. So this list is available on the website as well, right, Merce?
Yes, it is. It's listed under your webinar as additional resources, both on the WebEx site and the Nursing Home Social Work resource page.
Yeah. I see a couple of different, this is Debbie, I see a couple of different questions from Linda, and one of them says, how to get the nursing staff to listen to what you have to say. I go about it two different ways. One, I've actually been in the same nursing home for several years, so I have earned a lot of the trust from the staff, and a lot of the staff actually come to me and ask for advice. But when I feel that what I'm saying is falling either on deaf ears or I need, somebody else brought in, we actually have a licensed clinical social work counselor that we contract with. And I bring her in and have her do an evaluation from a completely objective point of view. And I go ahead and I have her write up approaches, which are very similar to mine, but sometimes when the staff sees that somebody from the community came in, I think what they're feeling is it's not that they're not listening to you, it's they want to be heard. They want to know that you're listening listening to them, that you're addressing their concerns of the resident who's hitting, of the resident who's refusing to take showers, the resident who's, screaming and being disruptive to everyone, because we're the ones that are providing the hands-on care. And so they want someone, it's not that they don't see us as a professional, but they want to see somebody who might not be biased with the resident, and they may be saying the exact same approaches that we are, but it's viewed in an entirely different way, and you've got to use those resources. That's also why we have a psychiatrist that we contract with too, that I work very closely with, so that staff can hear things from different people.
I will also add that those are great points, that your administrator, so one of the webinars last fall, we talked about, I specifically was talking about social work advocacy for ourselves and our profession, and what that would look like is talking with your administrator on a regular basis, whether it's every week, every other week, and the individual know what it is you need, how he or she can support you in your department, and being very specific and getting that support from administration. Because if you're having trouble getting staff to include you in the clinical operations, and I'm talking pressure sores and skin issues and weight loss and things that social workers don't normally see ourselves a part of, your administrator and DON have got to support you with all of this stuff here. So you have to have that relationship with the leadership in your facility to support you visibly with staff, because staff is going to follow what the administrator and DON do, hopefully.
Yeah, I agree with that. You definitely, there is the some understanding that sometimes the director of nursing and the social worker do not always get along. And I wouldn't say that that's necessarily the case. I say everybody wants what's best for the resident. We just go about it in a different way than nursing staff. One of the things that we have done here is we kind of divide and conquer. And I participate in a rehab meeting. I participate in the fall committee meeting. I know what's going on. I participate in our weekly weight management and dietary meetings. So I know who has pressure ulcers. I know who's losing weight. I know who has had falls. So when something comes up and they say, why do you think this resident fell or whatever, I'm not afraid to say my opinion about something. But again, it's something where our group also has an understanding, and Paige can probably say this, our group is rather a unique one where I'm not afraid to say something to other members of the team, even if it's not initially, because the goal is being an advocate for the resident and providing the best care that we can.
I'm going to jump in here just a minute. This is Merce. I wanted to let you know what the poll results were. Is your facility a leading age member? First of all, we asked the people who did not answer. I don't know if that's because they were only by phone and weren't to the computer, but those who did, 26% of the people online today are part of Leading Age, and 11% are part of ACA. And it's interesting to note that 30% of the nursing home social workers online today do not know if their facility is part of Leading Age or ACA.
Oh, wow.
I also want to say, so please find that out today. This afternoon before you leave, find out if you're a member, because they are also offering webinars, and they also have meetings, and they have publications that should be resources to your whole facility, including the social workers. So don't overlook those important resources. I want to also mention that our next webinar is February 20th, and we are doing a very fascinating webinar on Katrina and Sandy. So the nursing home experiences of Hurricanes Katrina and Sandy. Steady and ready tomorrow. I'll be putting this out on the listserv. Our speaker will be Barbara Frank, who has been very much involved with dealing with disasters and also with culture change, and then Deidre Downs, who's the Director of Social Work at Jewish Life Care in New York City. So all this information about upcoming webinars goes through our listservs, and then you'll be able to register about. So we have about a minute and a half left. Is there other question or any concurrent by Paige or Deb?
I do want to say it looks like Linda had another issue there. She wants to have more information writing cause and care planning. Wow, those are huge webinars in themselves. If I could pick just one resource from that list of resources, right in the middle, there is that one that I mentioned throughout the webinar, the New Care Plan Answer Book. To me, that is one of the most wonderful resources available that gives very great ideas, and these are based on real residents, that you could use to have some ideas for folks in your facility. It gives you some information about the care plan process. I referenced some of it in my presentation as well. So I think it comes down to getting some resources in your facility, and this here is a good start. So,
thank you, and thank you everybody for participating. The recording will be put online within a couple hours in case you want to listen to it again or let a colleague know about it. I'm going to stop recording it. However, if our speakers have agreed to stay on the line for another 10 minutes or so if people still have questions. So please feel free to ask another question if you'd like.